Thank you very much. So, good afternoon and welcome to our Governing Board meeting. I'm Dr. Elizabeth Fellows and I'm chairing the meeting today. We're meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available via the website. Today's meeting is being recorded so that in the event of the failure of technology, it can continue and will then be uploaded onto the CCG website as soon as possible. Bookmarks have been added to the pack of papers to make it easier to follow through, and so if anyone hasn't found those, you click on the left-hand side tag that looks like a bookmark. Now my phone's going off, that will give you the agenda items so you can move swiftly through to each of the papers. Hopefully that makes it easier. So just to remind you, keep your microphones on mute and only turn these on when you're asked to speak. Please only use the chat function to indicate you wish to speak, and do not use it for questions and answers because this is a meeting in public and the public won't be able to see the chat function. So can we go through the list, and please can I ask everyone taking part to confirm their presence. So if you can start off, Helen, name and title.
Helen Atkinson, Director of Public Health for Portsmouth.
Thank you. Karen.
Hello, Karen Atkinson, Governing Board Nurse for Portsmouth CCG.
Linda.
Linda Colley, GP and Chief Clinical Officer for Portsmouth CCG.
Carsten.
Carsten de Schaft, GP in Portsmouth, Clinical Executive for PCCG.
Graham.
Hello, Graham Love, lay member.
Nick.
Nick Moore, GP in Portsmouth and Clinical Executive on Portsmouth CCG.
Jackie.
Hello, Jackie Powell, late member for Portsmouth CCG.
Innes. Ooh, Innes's connection's not great. Andy Sylvester. No, Andy.
Good afternoon, Andy Sylvester, lay member.
Simon.
I'm Simon Simonian, I'm GP here in Portsmouth and also Clinical Executive for Portsmouth CCG.
Michelle.
I'm Michelle Spanley, I'm Chief Finance Officer.
Tawinda.
Hi, I'm Tawinda, I'm Secondary Care Consultant.
David.
David Williams, Chief Executive, Portsmouth City Council.
Lovely, thank you very much. We also have in attendance Jane.
Jane Collis, Jane the Minutes.
And Justina.
Justina Jeffs, Head of Governance for the CCG.
Lovely, thank you very much. So, moving swiftly on, we've got apologies for absence from Margaret Geary, lay member, and Dave Scarborough, Practice Manager Rep, and Alison Jeffries as Head of Children's Services. And I think otherwise everyone else is present and we're up and running. So good start. So register and declarations of interest. Anyone got anything to change on this? Someone usually has something. Might we manage this as a first? No changes?
Sorry, Elizabeth, this should be a standing agenda item for me because I have informed Jane about this. Actually, PPCA have been removed, but apparently they didn't actually get me to sign paperwork to remove me as the nominated shareholder. So although it no longer appears, it's only going to be removed as of tomorrow because I assumed that I had been removed from it when I left my former practice, and that hadn't actually happened. There's also an error on which of the committees I sit on, which is going to be corrected, and Jane knows all about that. So it's just to make sure that it reflects my attendance at Primary Care Commissioning Committee. Other than that, nothing substantial, and hopefully that will be the last change for a while.
Lovely, thank you very much. So my hopes were dashed, never mind. Right, so we've noted those with Nick's amendments, and then moving on to the minutes, and has anyone got any comments or corrections for these? Nick?
Just one minor typo under the comment which I made on page 4 about it should be understood and not should be understood and not understand on the comments I made on page 4. Other than that, that was the only thing.
Thank you. Michelle?
Again, just a typo on page 6. I think it says CCGH in capital letters. I think it should just say CCG. But my screen has just stopped, so I can go.
So that's in section 6A,
Yeah.
fifth paragraph. Yeah.
I have it. I have it.
Thank
Yeah.
you.
Lovely, thank you.
Jackie?
On page 9, we make mention of the patient engagement graph, and Justina and I are going to have a conversation about that risk and maybe reword it so that it perhaps reflects better what we're trying to say. So there's an action, it's in the action plan and on page 9 of the minutes.
Okay, thank you.
All right, you're welcome.
And then Graham.
Just a sort of matter arising rather than accuracy, Elizabeth, but just towards the bottom of page 8, where we were talking about the COVID-19 arrangement in care homes, the final sentence says those in Milton Village, Brunel and Maritime are outside of those arrangements at present. I just really wanted to check, does the at present indicate they may come within those arrangements shortly or not? Question mark.
As far as I'm aware, there is work going on to look at how better to support those in supported living, which covers those properties. I don't believe anything's happened as yet. I don't know whether Karen can update us on that at all. No. Don't know. Is Karen around?
Sorry, I was on mute. No, I haven't got any further information, Elizabeth, sorry.
No, that's okay. Thank you. I had a feeling nothing more has happened of it. We will keep an eye out for that, and in fact we'll add it to the actions to look out for that and report back as soon as we've got further information.
Okay, thank you.
Any other comments? And if we move on then to the summary of actions, I think these are now all complete with the comments from the review of the executive arrangements in PPCA as listed there. So that is a watch and wait, but that PPCA have felt they do not need to replace that individual. Any other questions about that? Right. Thank you very much. So we're being asked to agree those minutes and note the summary of actions. People happy with that?
Yes.
Agreed.
Lovely, thank you. So moving on to the annual reports and accounts. Now this isn't quite what I was expecting to be doing at this meeting, bearing in mind just under a year ago, Justina and I and Jane had set in motion what we were going to do for our AGM this year. Venue was booked, arrangements were set in motion, comms team fully involved, and yes, then COVID came. So we're not doing the big celebration of 5 years of transformation and improvements in the city. But I don't want to let it slip by in my usual style of saying, here's the annual accounts and annual report, let's move on. We've done brilliantly, and we've just got on and done stuff in the city very quietly, under the radar most of the time, and often way ahead of the national curve for things. I quite often hear of innovations around the country, and all too often they're things we're already doing and are business as usual for us. So Yeah, I'm really proud of everything that people have been doing. And in the past, we have done really well. We've got a lovely bookcase full of awards up in the offices. Not that many of us are seeing that at the moment either. But of late, we've just kept our heads down and we've got on with the transformation and as I say, put it into business as usual. I'd really like us to change that again. Let's see if we can't apply for some awards in the next round. We have some brilliant people working for us, and I think some national recognition wouldn't be a bad thing. We've also got delivery, and Michelle and I were talking earlier on today that we're not just talking about these changes, we've delivered them. We have delivered first contact physios before others were talking about them. We've got an acute visiting service that has saved primary care. We've got enhanced care home team that has worked right through the crisis supporting. We've helped the Hive. We've looked after the people of Portsmouth in a way that other areas have desperately struggled to do, and that's because we work together as a city. We have had some outside recognition of what's gone on. It's a bit dry because it's through our auditors, but these are external organisations that have just been making better and better comments every year about the state of the organisation, and they're always very complimentary of all the teams that they come into contact with. So we've got a little glimmer of outside recognition, but let's really seriously consider how we can go for a bit of glory, because our staff are worth it. So I would just like to say it's a massive thank you to all in Team Portsmouth. I'm so pleased I chose to come back to the city. I'm born and bred here, but I left to go to medical school and I've worked here ever since, and it's the best place to be. So we're getting it better and better for the city and our population. Let's keep up the good work. So that's my rant over, but I hope you will all support me in thanking those who put the report together, but also all of our team in doing the work they've done over the last year. Lots of nods. Hopefully that's okay, and that we can move forwards and chase people to apply for awards. So we are asked to formally note and adopt the report and accounts. Happy with that? Thank you.
Noted.
Yeah.
Yes.
So we now have B, which part B of this section, which is Innes, and I now have to flick over to something else. Can I pass over to Innes for his presentation? Thank you.
Okay, and I have fixed the sound issue, I hope, so you can hear me.
Much better, thank you.
Good, good. It's all to do with operator problems, I can tell you that. So I think actually this follows beautifully from your speech, Elizabeth, which I completely support every sentiment you made there. Because what I'm going to do now is present, in effect, it's the priorities and plans going forward for health and care Portsmouth. But this is based on what we have been doing over the last 5 years. And what this document does is actually describe every single bit of work that we intend to do. And all of that is based on what we have managed to achieve over the last 5 years. And if you think that the presentation running at however many pages long is too long, that's because it's attempting to describe everything we do. And I will confess I had a moment when I saw the first draft with my strategy hat on, thinking, oh God, we've got a strategy of umpteen pages here. And then I realized all it was doing was describing the breadth of work that all our teams and our partner teams are doing in the city. It's not proposing a new list. It's actually describing what we've done and what we want to do next. So it actually stands as a great descriptor of the work that's been going on. And better than that, it starts to describe where we want to go to next. So what I'm going to do is I'm going to highlight a couple of the slides. So I'm not going to go through each of the slides and the rationale and the next steps. I know that Joe York has joined us as well. Joe's been doing an awful lot of work on this as well, and Joe will contribute to this. Sadly, I know we haven't got Alison, and I don't think we've been able to get anyone from Children and Families as well. So we will represent their work on this. It's involved in this. And also I know, Helen, that you and your team have been involved in this piece of work, and we've got the public health priorities on this, which you are obviously more than happy for you to talk to when we get to that as well. But I don't want to just drop you in cold. So what I will attempt to do is, I know people have got the PDF in front of them. I will try and share this on screen for the benefit of people watching from home, if I can find it. Let me see. Let's try this. Nope. As always, HT. What's that? No. Isn't that great? It works every other time except when you need it. Let's have a look here. There it is. Is that on screen?
Yes, I see that, Ennis.
Brilliant. So for those of you with, I was going to say long memories, but it's 5 years ago, we developed with partners and people in Portsmouth a Portsmouth blueprint. And that essentially was, as it says, a blueprint for how people wanted their health and care service delivery to be in the city. And we've used that as a bit of a roadmap for everything we do in the city on health and care. One of its core aims, and this very much came from talking to people who use services and live in the city, and also our GP members and our political membership in the city at the time, was there was a core aim to bring together and integrate services where it made sense for individuals working across organisational boundaries as well. And we produced this in 2015, and the partners, particularly on the NHS side at the time, signed up to that as well. It's 5 years on and a lot has changed, and we've all been through the COVID response and are continuing to go through it. So it is right that we refresh this and just check this is still on track. And this is what we're doing at the moment. So this is a bit of an update. And the aim of it really is to ensure that we have a set of strategies broadly in the same format that set out our 3-year priorities for adults, children and families and public health. And that when we take them together, they describe that full range of health and care intentions for the city. And as part of that, we're reviewing and refreshing those health and care Portsmouth commitments as well. And the idea is to have a clear set of priorities for Portsmouth so that we are collectively clear. And also through working with all our partners, be clearer on which of the work we need to deliver in the city and which we need to work across boundaries into wider Hampshire, into Portsmouth and South East Hampshire, and which partners we need to work with. It also helps us prioritise the work for all our teams, and it also allows the board and the council to agree which partnerships it needs to prioritise in order to deliver the work. Just to refresh your memory, and I won't go through this rather busy slide in detail, these were the commitments, the blueprint commitments that we agreed in 2015. And in starting the conversation amongst partners and people around these commitments and refreshing them, it's quite clear that some of the fundamental of these have not changed, and people still want to deliver on this consistently and repetitively for the city. We have had some feedback, so I'm just presenting here now some of the proposed revisions to these commitments. Again, I won't go through in detail. Things to note is there is clearly and obviously a strong desire to have an upfront commitment to continuously working hard to improve quality of health and care in Portsmouth, working with our individuals, our communities, and making sure that we work across the diversity of local communities who live in Portsmouth. The other things to note is there is a strong commitment to bringing together and integrating not just our frontline services where it makes best sense for the person who uses them, but also all of the other supporting and enabling functions that help those frontline services do their job effectively. So that ranges right across things like preventative strategies, how we work with communities, to HR, estate, IT, and other support services as well. So these commitments are going out slowly for people to comment on. I know this board has had an opportunity in August to have an initial look, and there will be further revisions coming in, and we'll bring those back to this board as well as other partners when we've got those comments in. The refresh of the plan will effectively look at public health priorities, where we are working together on health and care, public health priorities, priorities for adults and priorities for children and families. And then there will be a range of what I'm going to call cross-cutting plans, which deal with those very important issues such as quality, such as safeguarding, such as our financial strategy, such as HR and workforce, that will be cross-cutting across everything we do. So all I was going to do today was talk about the public health priorities that we are putting together, the adults and the children and families. Helen, I don't want to drop you too much in it, but would you like to talk through this particular slide on the public health priorities?
That's absolutely fine. Thank you, Ines. So you would expect to see, so you'll notice in the presentation that there are many slides both for adults and for children. So we've joined this conversation more recently, and therefore there's just one slide currently, but we will continue as a team to work together with our colleagues in the CCG and in children's and in adults within the council to further develop. Now, I suppose the bit I wanted to point out that when you look through the slides, and this takes us through the rest, you'll see that there is a lot of consistency in approach. So on the left-hand side, the 6 priorities are particular areas where we either have a statutory function within public health, either to lead or deliver, lead commissioning or deliver. So they won't be surprised, I won't go through them, but they'd be the things you'd expect to see. But the bit I wanted to point out specifically is that there's a strong connectivity between all of the 6 priority areas in public health and the work in children's and in adults in the following slides. And the purpose of the work we're wanting to continue to do is ensure that that comes together, so that actually we are delivering together, we're prioritising together. And so clearly, if I just take one as an example, around adults, it's working with vulnerable people. We do a lot of work jointly with our homeless population, our homeless and sleeper population. So rather than us doing that separately or in silos, it's really ensuring that we are doing that work together and continue to do, I'd like to say, that work together. So we've worked very closely together to ensure that our homeless population have a strong primary care and health provision, and we have worked together both with the CCG, within the CCG, and with the acute hospital to provide HPV and TB screening as an example for our most vulnerable population in the homeless hostels, as an example. And then, so none of this work is in isolation. And what we want to do is, as we move forward, is to continue to strengthen and make sure that that work is actually clearly connected. So as we have a wellbeing service, and the adults team have do a lot of work around independence. How can we, moving forward, ensure that that is much more connected for our population, so that it's a seamless delivery of care, as an example. And then on the right hand side, I just want to mention the cost-cutting programs, because what we want to ensure, so a lot of the work that we're doing currently, you'll be aware, is around ensuring that we work across the NHS and we work across partners and local government around COVID response, COVID-19 response. But a focus of that has been on initial response, but actually there's a huge amount of work around wider determinants or inequalities as well around that work. So we now know through the COVID-19 pandemic that people from our more vulnerable communities are likely, so that includes our BAME communities, our older communities and those with underlying health conditions, and our deprived communities, there is a much more serious consequence of COVID-19. And moving forward, how can we tackle those underlying wider determinants or causes of the causes of ill health, as we like to say. So a big focus on not just responding, but how can we ensure moving forward we are really starting to tackle the causes of ill health, which could be both physical as well as mental health and emotional well-being, and could be, when we talk about physical health, could be around things that are caused by or focus on health improvement as well as health protection. And underpinning all of this work is the partnership through the work that we're doing in the Health and Care Partnership about understanding what those causes of ill health are and how we in partnership can tackle them together, from educational attainment, employment opportunities, housing, transport, planning in the built environment. So big focus as we identified at the beginning of the first wave of COVID-19 was air quality and the impact air quality has on health, as an example. And then just finally, in terms of the cost-cutting programs, a real focus on strengthening the intelligence and evidence function, both for the CCG Council and Portsmouth Health and Care Partnership. I think that what has been a huge strength through the COVID-19 response that we've worked in partnership across health and care is around ensuring that we are using the best intelligence insight of the COVID-19 infection, as well as the evidence of what works. And I think that has really set us up moving forward to ensure that we do that work and continue to strengthen how we work around our insight and intelligence. So really, that's probably it for me, Ines.
Okay, thank you, Helen. Thank you very much. Now, as I said before, we haven't got Alison here with us today, but both Alison, Jeffrey, and Hayden Gins and our integrated children and families team have been actively involved in this. And what this slide does, it describes the top level priorities which are contained in the Children's Trust Plan and are currently being refreshed for children and families in the city, including what they describe as a strategic spine, which is 5 areas that all those strategies need to incorporate and progress. I will just go through this slide, and the following slides gives you some of that underpinning detail about the actual work involved in delivery of much of these. So clearly there's a priority around improving education outcomes. There's a significant emphasis on improving early help and safeguarding, and that's something that there has been strong joint work across the statutory partners for some time now, but their safeguarding strategy, I think, sets out a helpful and ambitious programme of work for us in the city. Improving physical health is a key one, and improving social, emotional and mental health, or the SEMH strategy as well. The corporate parenting strategy looks to improve outcomes for children in care and care leavers specifically. And the SEND strategy specifically focuses on outcomes for children with special educational needs and disabilities. And threaded through all of those, there has been significant work locally between parents and local residents, as well as services and service users, to agree a deal with parents, a social contract with families to co-produce how we develop and plan and deliver services for children and family in the city. And a big part of that is around adopting restorative and relational practice, looking at trauma-informed practice, and particularly at the whole family. You will see that in this, and when Joe talks around the adults, there is significant amount of overlap here, and certainly Alison, Helen and I and our teams are in conversation around a whole family approach so that we get a much more coordinated offer of support in our communities around families, because quite often that can work with individual children can be hampered if the aligned work with adults around them hasn't taken place. So I'm not going to talk through the detail of the following slides. They are there to give you some assurance that there is underpinning detail and between each of those priorities and plans. And even these slides, under each one, that A, B, C, D, there will be further detail and a list of projects as well. It is based on existing programs of work and it sets out the next 3 years. So I will just very slowly go through these so that they go up on screen. And I hope Alison forgives me for doing so, because I'm sure there will be things that she would want to highlight. This pack obviously will be available via the CCG website in the usual manner, so people can read it at their leisure as well. And then in terms of priorities for adults, Joe, do you want to talk us through in a similar way of that? Because you've done a significant amount of work on this. Thank you, Joe.
Yeah, thank you, Ines. And yes, I think the adult journey feels we're slightly behind children's in terms of where they are and being able to outline those strategic priorities, and that's where and strategic objectives, that's where we're getting to. So this has been very much linked to the refresh of the blueprint and the coming together of all of the adult work that we're doing around adult social care, the CCG, the work we do in partnership through the Portsmouth Provider Partnership, formerly called the Multi-Specialty Community Partnership, but that's really where most of those partners who are at the front of this slide pack come together and talk about some of the adult objectives, and also how we work in partnership with Portsmouth and South East Hampshire. So as you said, Ines, this isn't about anything new necessarily. This is about building on everything we've done, refreshing the successes that we've got, where we still feel we've got work to do, and I think we always feel that. I think that's probably one of our strengths and successes in the city, and the reason we don't always celebrate is we're always thinking, yeah, that's great, but now we need to do this as well to make it even better. So yeah, definitely take on board the need to stop and celebrate, and I'll try and do that a bit as we talk through, but also how we have taken on board learning from COVID and what that's meant for each of these areas. So 6 priorities for health and care for adults. The first one is personalisation and care and support, and again, not new. This is something we work really hard in adults health and care to do, and we get better all the time. But some of the key elements that are within this at the moment is building on and commissioning in line with the domiciliary care review and intervention that Adult Social Care did last year, which was really powerful in looking at domiciliary care provision in a new way, using really up-to-date technology and apps around when carers were going into people's homes, what the issues were being able to give real-time information to carers and families and adult social care, which made a huge difference. So really trying to think about how we can commission that as a more business as usual approach, and lots of work being done around that. Also key within this, and again linking from our learning from COVID, is around strengthening and building on all the work we've done around end-of-life care planning and future care planning. Lots of work that our primary care teams have been busy doing and community care teams have been busy doing around this, but it's really making sure now that patients and the people and their families feel engaged in that and understand that planning as well, and that plan stays with them and is able to be worked on by paramedics and the specialist community teams, so that people are supported around the end of life journey that they want and that they've described, and have dignity around that. Another key area within this is the restoration of CHC assessments, which have been paused during COVID, but will get back up and running from the 1st of October, and making sure that the default of that is a personal budget, so that it's really around that personalisation of care and support for those most complex in our community. Improving health and wellbeing and strengthening our communities using an asset building approach. As Alison said, I think we've had some really exciting conversations recently with public health around this, and with children and families, and how we bring this together. But I guess some of the key ones I just wanted to pick up really was around all the work, the amazing work that the Hive has been doing, and how we really strengthen that partnership with the Hive as kind of the gateway to community services, building on the community help desk, which was absolutely pivotal and an organic development through COVID to help those people shielding in the city, and look at what our community offer needs to be. We're embedding social prescribing now within primary care, but how do we make sure they have the right offer and are connected to what's going on? So that's really important to us around that one. Oh, sorry, next slide, Ines. I was going to talk just to the one, but that's fine. Strengthening primary and community services. Again, the blueprint is the heart of the blueprint, I think, is that foundation of primary care and the support within the community in the city, and that being delivered in an integrated way. Since then, we've had primary care networks coming into play, enabling practices to work more closely together, and we have 5 of those in the city. So we need to continue to strengthen those and build on that, and also build that concept of a one team approach around the neighbourhood model with the voluntary and community services, primary care staff, community nursing staff and social workers, and the allied health professionals as well. We made some good strides around before COVID. I think COVID has changed some of how we need to deliver that, because people are just changing, or services are changing the way they deliver those individual bits, but really important we don't lose sight of coming together around that. Integrating our intermediate care, we've made huge strides in this in the city, better than a lot of areas, I think, and that's enabled us to move in line with the national discharge guidance through COVID, teams out of the hospital, and to have a really effective, really integrating hub that makes sure people spend much less time in hospital than they were before, so that then there's much fewer delays, which is really good for people. So really building on how that operates, but how we enable that to be a step up provision as well, so to keep people in their community and to avoid hospital admissions if they're not really necessary. So that's probably that one. Next one. Supporting vulnerable people. Again, our learning from COVID and our ability to work so closely in partnership with in the city has meant, I think, we have been able to really improve, or we've been able to support those most vulnerable in our community at this time really well. So again, building on the work the Hive have done with shielded patients, how we support people with long-term conditions. We know post-COVID that those people who are more clinically vulnerable, who have a long-term condition, perhaps maybe in BME community, are more vulnerable now. So we really need to reach out to them and make sure that our flu prevention programme is absolutely reaching those harder to reach groups, and that will be a challenge for us, but it's one we again, working in partnership, need to take on. And we need to think how we build on supporting people in their community with a long-term condition, and how we help them with all that well-being support, and again, there's services out there, how do we make those even better? Care homes, again, we've come together really well, I think, and helped our care homes in the city through this period. We've had some really good feedback to our teams, and that's about public health, the CCG's quality team, adult social care teams, all working together to give the right information to the homes, to make sure they don't have to jump through lots of hoops, and in developing that enhanced care home support, so they have proactive support that enables them to manage people safely in their homes without hospital admission if not necessary. And the next one. Again, lots of work that we do in partnership with South East and Fareham and Gosport around acute, secondary and specialist services, and how we continue to improve that, particularly post-COVID, where we know we have longer waits potentially as a result, and how we get back to restoring our essential acute services and looking at where we can do things differently. And again, lots of success stories within this. Prior to COVID, we had a big programme of work around transforming urgent and elective care, which would significantly change how we commission services in the future, moving to a much more integrated approach rather than standalone services, of which you can find people almost ping-ponging between services, both in elective and urgent care. And I think we've had to pause that commissioning strategy through COVID, but we're getting it back on track now. And actually some of the learning and the way services have come together through COVID is absolutely in line with the model we were trying to develop, both in urgent and elective care. And the management of those waiting lists in elective services is being done less on a service and specialty specific basis, but much more at a system, both locally in Portsmouth, South East Hampshire, but also at Hampshire and the Isle of Wight, so that we're making sure that we minimise the delays wherever possible. And actually, I was on a call this morning within Portsmouth hospitals, the use of advice and guidance, and how well our GPs, both in the city but in South East and Fareham and Gosport, have reacted to that, means that we're seeing a very different profile, if you like, of referrals coming in, and it's enabling us to get back on track much better than perhaps in some areas. So we're the top in the country for advice and guidance, and that means that GPs can get electronic advice and email conversations with consultants about their patients there and then, which may prevent referrals or prevent any delays for the patient. One of the things I think we're all particularly proud of in the city is our integrated primary care service, which is managing our community urgent care demand and has changed the way GP out of hours operates in the city. That's a local service. We have a local clinical assessment service direct from 111, which means we have more clinical validation and are able to get patients to the right place and managed by the right clinician, often over the phone or through an effective triage route, rather than having to go to ED or another service. And that's a really good service. When we look at the metrics around key out of hours services, our provision now is significantly better than it was 2 years ago when that service came online. Because of that local CAS development within that, we've been able to be again working with colleagues in South East Hampshire and the Hospitals Trust, an NHS 111 first early mover, which means again strengthening, reducing infection rate risk at the ED, reducing the number of people who may attend to ED who might not need to be there, putting an appointment slot around that so that people ideally phone 111 first or use the online services. They get directed through to the CAS if they need to, can get primary care support, and then if they really need to go to ED, they're given an appointment so they know when to go, reduce that number of people waiting at the front door and therefore that risk of infection. So it's a really exciting opportunity that we've got that's based on the work we've done in the city, that's now sort of rolling out to other partners across Hampshire. The last slide, and then I'll stop. Again, mental health, lots of work we've done in mental health in the city, and we know post-COVID that we are likely to see an increase in mental health demand for our services. We need to strengthen the role of Positive Minds. That was a service we set up post-COVID, really with that lower level wellbeing support, but able to access specialist services as required. So we really need to build on that. It's working in a very different way now. It was designed as a drop-in service. Obviously that's quite difficult to do, but they've been doing lots of virtual and telephone support to people. And again, in mental health, really building that one team approach so that we're not bouncing people around between services. We're able to direct them and support them to get the right care that they need. And again, looking at how we can manage people with mental health concerns away from ED, because that's not necessarily the best place for them to be, and have a much more proactive service out in the community. And Solent and Southern are working together with the Hospitals Trust around that at the moment. So that's it, really. That's where we are and where we're heading.
Okay, thank you, Jo. So very briefly, for people who like a diagram, this is to describe what we're building here, or bringing together, really. There is a Portsmouth Health and Wellbeing strategy driven by the Health and Wellbeing Board, and that there is a process around that that obviously encompasses a much broader range of initiatives and priorities than we're describing here in the Health and Care Portsmouth plan. There's a set of Health and Care Portsmouth commitments, which I talked about earlier, and a set of public health priorities, which Helen outlined, and as Helen also mentioned, cuts across everything we're doing, hence the position I'm showing them here. Then there's a range of specific priorities for both adults and children, and these won't succeed unless we have strong plans for things like quality, safeguarding, how we work with our market and contracting, our finance strategy, etc., etc. So there's cross-cutting, cost-cutting. That was a Freudian slip, wasn't it? Cross-cutting programs that support the delivery of those strategies. So very final slide, just to give you a flavour of next steps. We're going to complete the work on the detail of those programs. All of the strategies are being refreshed at a slightly differing rate depending on their maturity and age as well. But as Jo also mentioned, we've recognised as we've done this, there are many areas where instead of having separate work plans, then actually we'd be stronger in coming together, bringing together public health, children, adults, and other partners to deliver that as well. There's a piece of work to connect this to both NHS and local authority planning. That's both operational and financial planning requirements and timescales, and we have a good history in the city of bringing the City Council and the CCG's financial planning aligned and together along that line, and has helped us most recently in the COVID response, for example. And we also need to go and talk to all the partners in the various boards and partner organisations as well. Some I've named here, but there will be others as well. And in doing so, we'll have a discussion and come to a set of recommendations that says actually some of this work absolutely needs to be delivered with different partners outside the city at the various tiers that we all work at as well. And aligned and alongside to that, we are using this to inform the priorities of our teams and individuals in those teams, and are thinking about CCG and City Council integration as well. So Elizabeth, apologies if that went on slightly longer than you were hoping. It's hard to describe the huge amount of work that's happening on health and care in Portsmouth very succinctly without doing someone a disservice. So I hope that gives board members a flavour of where this work has got to and the breadth of the work that we are both delivering and planning to deliver over the next 3 years. Thank you, Elizabeth.
Oh, thank you very much, Ines and Jo, and I'm sure Alison is disappointed she's not able to shine more of the spotlight on the children's stuff, but please do read that in more detail when you get a moment, because there's a wealth of information there. Have people got any questions or comments on that to Ines or Jo? Jackie?
Hello, I was going to say thank you. I thought that was really, really helpful, along with, I mean, when one of the true updates, and I found that also incredibly helpful in describing a very complex contract, but for us looking at transformation, I found that incredibly helpful. The only tiny comment I'd make around the children and families is when we're looking at those 1, 2, 3, 4, 5 spines, strategic spines, I thought of the first one, should we say a deal with parents and carers, just because not everybody has parents. I don't want to exclude them.
I will
But
certainly
thank
feed that
you.
back, yes.
Thank you very
Great
much.
piece of work. Thank you.
So Linda and then David.
Yeah, so I just, because Alison's not here, on Monday there was a very successful Teams meeting with all of the partner organisations for the Children's Trust, going through the priorities. And I just wanted to reflect that the wide range of organisations that are involved and the willingness to do it as a team of Portsmouth, you know, all taking responsibility. It's not obesity, oh, that's public health's problem. Obesity is everyone's problem. It was really that collective ownership was great. And I would reflect on the spines. We very much value that idea of having a partnership with the parents and or carers, but actually that needs to be with adults as well, doesn't it? So having a partnership with patients, public, whoever, however you want to phrase it, but it is a team effort, and all professionals will do our bit, but the public have to do their bit too. So yeah, I would like that in all of the topics ideally.
Thank you very much, Linda. David.
Yeah, thank you, Liz. At the beginning, you said how proud you were of the achievements of the CCG over the last 5 years, and I'd certainly absolutely endorse that. And I think also that presentation, and thank you to all involved, really does go to demonstrate what we've achieved and what we intend to continue. And it's just noticeable how much of it is dependent on interagency work. And I think also in terms of the city's response to the COVID crisis as well, and the involvement of the voluntary community sector through the Hive in that, you know, I think we should be, and I certainly am, and on behalf of the City Council, hugely proud and impressed by the work that the CCG's done and how determined we are to continue to work closely as we possibly can with you for the benefit of our residents. I'm absolutely sure Alison will be very pleased to take on board the comments, Jackie. And yeah, she is sorry she can't be with us. But I think, you know, particularly over the last 12 months, I think we've really accelerated in that area. And it's great to see both the work with children's and the work with public health really motoring now. So thank you all very much indeed.
Thank you. Right. So I think at this point we will move swiftly on to Linda's report, if people are happy.
Thank you. I'll keep it quite brief after that lovely introduction there. So I wanted to start with some good news. So as you know, Helen is our Director of Public Health. She was an interim arrangement, but I'm delighted to say that she's been permanently appointed, and the Council has approved that all through with the Director of Public Health and the Secretary of State. So that is a permanent appointment, Helen. So congratulations, and we're so pleased that you're staying. And again, that will help us motor through now some of these improved work streams. So well done. On a more serious note, Child Eye Serious Case Review was published, and there is a link there if you want to go and read it. It's always sad when we have to do these reviews, but it is really important for our learning that we do them, and we do them well. So have a look if you're interested. The link is there. The other thing I was going to mention was as we are now deep in planning mode, so phase 3 guidance came out from NHS England with what is expected now post, you know, kind of in the third phase of the NHS response to COVID and planning for the NHS. So there's lots of work. Our teams are very involved with this at the moment, and also obviously on all the different layers and Hampshire and Isle of Wight. Our first submission was done at a Hampshire and Isle of Wight level on the 1st of September. We have had response to that, and the teams are now busy working for the final submission, which is due on the 21st of September. So that's all going on at the moment. Some more changes in terms of personnel. So Solent NHS have appointed a new clinical director, and it's none other than Dr. Jonathan Lake, who you'll remember was one of our clinical executives. So we're delighted we'll be working with him again in his new role, and wish him all the best for that. Solent has also got Sue Harriman, who, as you know, is their chief exec, is going to be going on a temporary secondment to work with NHS England. So we'll be working closely with Andrew Scrivens as a temporary measure until her return. So that's good news for her. Portsmouth Hospitals is no longer Portsmouth Hospital Trust. It is now Portsmouth Hospitals University Trust. So again, great for the city to have a university hospital working closely and that will really bring benefits to patients and also encourage new workforce in and hopefully new technologies and things to develop. So really excited about that, and really as a city we need to get behind them and hope they can take all the opportunities that brings. Portsmouth Hospitals are also working more closely with the Isle of Wight Hospital and Melanie Poole, who, as you know, is the chair of the Portsmouth Hospital University Trust, is now also the chair of the Isle of Wight Hospital. So I've got to get it right, of the Isle of Wight, of course, NHS Trust. So she'll be chairing both boards, which will help oversee that partnership working. And our very own Dr. Jim Hogan, who, as you know, was my predecessor, is now the Associate Medical Director for Primary Care, working with Portsmouth Hospitals University Trust. So again, general practice working very closely with secondary care to really smooth out those problems between primary and secondary interfaces. So again, good news for them. In other news, the GP patient survey results are out, and we've put some headline findings for Portsmouth there. Often it's very difficult to compare because often the numbers are relatively low, so you have to bear that in mind. But roughly we're sitting around national. So with 81% of respondents described good or better for their overall experience of their GP practice, 82 is national. So still some work to do, but you know, not too far off what national is. And some surgeries coming up quite highly on the surveys, notably University Surgery, Kirkland's and John Pounds there. So that's just there for your information. And the final thing I was just going to point out is EU exit planning. So our topic that was our favourite one pre-COVID is now back, and Tracy Davis is busy representing us in the meetings. It's going to be regular meetings again, just keeping out for the key risks. But we are preparing for a no deal on the 31st of December, so, and it will not be extended as it currently stands. But she will keep us updated by regular attendance to those meetings as and when we need to know. But I put on my paper the previous concerns are obviously all still there about a no deal exit, and they'll all just be working through. There's many work streams going on now to work through what that would mean. And obviously the council is heavily involved, as are our other partners, but Tracy is our main link in through that. I wasn't going to say any more unless there's any questions about any of that. Sorry, it was a gallop through. You're on mute, Elizabeth.
Sorry, Graham and then Jackie.
Just a couple, Linda. They're not connected. You talk in one part of it about the premises improvement grants and that one of our applications has been prioritised. I didn't know if you're able to tell us which one that is.
I'd have to go back and look, and unless anyone knows, Jo, do you know off the top of your head? Is she still with us? No, I can go back and find out, Graham, and I'll get that sent to you.
And the second one was just about the patient survey. I assume practices sort of use that as a way of also looking at sort of action plans moving forward, if there's any particular areas that they seem to be coming low on. Is that fair comment?
What usually would happen. So the practices would get their direct access, and you can compare yourself against your neighbours and against the CCG targets. And we in our practice visit rounds that we tend to do annually, it's the kind of thing we'd have a chat with them about if there was any concerns raised or if they were significantly falling in an area. It's the kind of thing that we bring up at that forum just to see, is there a reason why? Have they looked into it? And if there's any support they need to improve. Obviously, a lot of the things now will now be changed because of COVID. So a lot of it is about access, and obviously access is now a major issue. It's hitting the national press. And so, there is a need probably to do some more communication with PrEP patients about how we're accessing in the new world, because the new world is digital and kind of telephone contact first, and then face-to-face when clinically indicated. And it's that kind of messaging that we need to just go back out now and just make sure people understand how to access with the change in circumstances that we've had.
there's a couple of tiny typos, but I can send them over to Jane maybe afterwards.
Yeah, that'd be lovely. Thank you.
Yeah. Okay. My question was around the mental health investment submission, which I thought we'd sorted out for this year and got done, but it seems that a finance submission will be required soon, and I didn't quite understand that or what that's about. So I don't know if there's any more information around it.
Michelle, maybe.
Yeah.
Need to take that one.
Great.
So you'll remember that we went through a process, and the auditors have now we've just been able to sign off 1920. So that was 1819, 1920 comparison.
Yeah.
What they're talking about now is how do we move to do the, sorry, I beg your pardon. I'm getting my years muddled up. Anyway, it's next year that they're looking to do, and now I can't remember what year it is. Because now I'm confused. Yeah, but it's the next year that we're talking about, and what does that mean? We're waiting for some more guidance about the approach to the audit and what the expectations are around the audit, because we did have quite a few problems through that first initial audit process in terms of expectations of what the parameters were. So they're just trying to make sure that that's much clearer this time. We need to publish it by the end of January 21, so it must be 1920 that they're just about to audit. So we're sort of a little bit behind the times in terms of how we would expect audits to happen, but that's the timeline we're looking at. So that's what we're talking about, is the next submission, which is based on the 1920 information that we need to publish by January 21.
Thank you, and hopefully that doesn't in any way hinder all the practice or all our aspirations and plans for how we do look at our mental health, children or adults or anything.
Absolutely not, Jackie. From our point of view, we just need to be getting on with the investments that we were expecting to do and expected to do, and I'll come on to that shortly about the next stage of the phase 3 planning. Because in some ways, some of that mental health investment standard stuff is a technical exercise, and in my personal view, might not be actually looking at the right measurements. So we need to be making sure that we're hitting all the other performance indicators, don't we? So that we can continue our good success in the mental health area.
Brilliant. Thank you. Yes, completely.
Because I am very conscious that we've got Helen next, and she needs to leave the meeting by 12:30. So, Andy, I'll take yours as the last comment for now.
Thank you, Chair. Just to don't to dwell on the spectre of Brexit, but the work that we're talking about here relates to transmission and the threat of the city becoming gridlocked if the port becomes endangered as a result of movement of vehicles through there. But a lot of work's taking place through the Local Resilience Forum, and I'm engaged with Tracy Davies just to ensure that we keep a handle on things. So be assured we're doing our best.
Fantastic. Thank you, Andy.
Thank you very much. And we're asked to accept this report. People happy with that?
Agreed.
Yes. Thank you very much. Can we move on now to Helen for her verbal update on COVID-19?
Thank you, Elizabeth. Although I did say I'd do a verbal update, I thought it might be sensible to use the weekly information summary that gets updated on the Portsmouth City Council website on a Friday as a means. So I won't take long, and I won't do every single slide, but I thought it would give a good summary. So I'll quickly share the slide set, and just to say that there is no information on here that isn't in the public domain. Obviously, this is a public meeting. So just a quick summary of the intelligence summary. We produce this each week. It goes to our Portsmouth City Council Gold meeting. It also goes to our Health Protection Board, and then we share it with the CCG governing body, also with all schools and all care homes in the weekly briefings, and it does go up on the Portsmouth City Council website on a Friday. So we cover generally infections or new infections, case rate per 100,000, the the epicurve, and then all the new infections across Hampshire and Isle of Wight, for all of the upper tier local authorities, and then deaths and early warning indicators. So if we start here, which is with the case rate per 100,000 population across Hampshire and Isle of Wight, and you'll notice that the Portsmouth line is the reddy brown bottom line, and is lower currently in terms of rate per 100,000 than all of the other areas across both Hampshire and the Isle of Wight, London, South East and England. However, I just would like to point out, which you'll probably notice, that the end of that line, so if you take from around 31st of August, beginning of September, you'll notice that it is beginning to increase in terms of our infection rate. And this is then our epicurve. And again, you'll notice on the left-hand side of that, lots of infection activity during first wave, during March to May. Then it pretty much flattens over the summer, but as I've just said, you'll notice that it's beginning to increase through the end of August, beginning of September. And we've now had a total of 600 confirmed cases since the beginning of the pandemic in March. Then this is our infection spark lines, and you can see for all of Hampshire and Isle of Wight up to local authorities data, and all you will see are all beginning to increase now at the beginning of September. And then when you just quickly take each individual local authority area, Portsmouth has had, as I said, 600 total cases, and in the last 7 days we've had 19 new cases. I'd like to mention that is, for those of you that look at this regularly, obviously a few weeks ago we were at a lower number, but this number does include 11 confirmed cases from our current naval-based situation post pre-deployment testing, and so that has increased that number quite a bit. Then Southampton have had 1,060 total cases and 13 new cases the last 7 days. Isle of Wight still in terms of the lowest, in terms of the actual numbers, with 449 total cases, 6 new cases in the last 7 days. But even the Isle of Wight is starting to go up. So for the last few weeks, they've either been at 1 or 2 new cases in the last 7 days, and they are now starting to rise as well. And then Hampshire, which has obviously got the greatest population number, have got 5,647 total cases, with 83 new cases in the last 7 days. This next slide gives you a weekly rate of COVID-19. So it's that same weekly rate, 100,000 for each of the upper tier local authorities. But we wanted to put some comparators in. So it's really important still to note that Portsmouth has got one of the lowest infection rates in the South East region, and the South East region itself is the second lowest region in the country, the South West being the only region that is lower. On the left-hand side of this slide, you will see the England local authority cases, and obviously what you'll see is pretty much the whole of the South East and South West are still in the lowest 2 areas, well, not quite the lowest, but the light blue and the light green areas on the left hand side. And you'll see that there's much higher rates per 100,000 in the north, the northwest, and some areas in the Midlands. So if you actually look at the table on the right hand side, you'll start to see that comparator. So currently the South East is at about 14.4 rate per 100,000. England itself has gone up, obviously, because we are seeing more cases in the north, east and northwest and Midlands, is at 30.5. So it gives you a comparator. This rate does fluctuate, particularly if you've got small numbers. It does fluctuate a little bit, but we are now at 11.2 rate per 100,000 in the last 7 days. And we compare very well when you start to look at the areas that have been in the 20 watch list, government watch list, so the Blackburns, the Bradfords and the Oldhams. And just as an example, it's really important to note that some of those areas have been in their own local lockdown measures and that has really improved their case rate per 100,000. So a few weeks ago, we were seeing Blackburn and Oldham well over 100,000 cases per 100,000, and you'll see that Bolton is currently in the hot spot there at 121.9. Then we look at our deaths, you'll see that that very much has gone down in terms of deaths from the first wave. So in the first wave, obviously there were significant deaths related to COVID in hospital, and that has gone down to to none from the 11th of April until quite recently. So we have had one COVID-19 related death at QA. And if we then quickly just look at because we don't tend to just look at numbers, we tend to look at our excess deaths. So the excess deaths gives us the average deaths in the corresponding weeks for the previous years, 2014 to 2018, and you'll see that the purple line is that average deaths in corresponding years, and you'll note that the excess deaths over than expected were during that period from about March to May in terms of our first wave, and then has consistently been below the expected deaths in the average week until we had a bit of a blip since week ending 15th of May. So they were for 2 weeks in 2 situations in August above, but those were deaths related to the heat wave as well. So that was the 2 very, very hot weeks. And then just quickly, I thought it would be helpful just to show that as well as following the case data, so confirmed cases across Portsmouth, we're also looking across Hampshire and the Isle of Wight, but this is actually Portsmouth data at what we call our early warning indicators. And this is just an example of 2. So we have seen a big rise in COVID-19 111 online activity in the past week. And I would like to say that this is mainly related, so you can see it in the first table on the right, mainly, and it's obviously been down, consistently down over the summer months since May. But I would like to say that most of the queries that are coming in on 111 online activity are around the issues around testing and access to tests at the moment. And then on the bottom left hand side is showing you an age breakdown, and you see that there's an increase in COVID-19 111 calls for 0 to 18-year-olds since schools returned at the beginning of September. So again, I would like to suggest that majority of those are also related to some of the issues around testing. And that's it. So I will unshare the slides. Thank you, Elizabeth.
Thank you very much, Helen. That's very interesting. It's really nice to see the Portsmouth figures quite so clearly. Sometimes I get a lot of reports which are across Hampshire, and it's quite often tricky to pick out the Portsmouth bits, so that's really helpful. So thank you very much. Any questions or comments to Helen? Bearing in mind, you're all right for a few minutes, Helen?
Yes, Elizabeth, that's fine.
Yeah. Nick.
Yeah, I've been hearing some reports that obviously, and maybe this leads into some of the other planning discussions that we've talked about before. Andy made reference to this, that in the event of this no deal situation, that the local testing site at Tipner might potentially be having to be looked at. Is that something that we need to know about, or is that something that's flagged up? David, you're also nodding your head. Is that so? Someone can maybe address that.
Yes, I'm happy to take, and David can come in. So yes, so the Tipner site, our current regional testing site. So it is the regional testing site for the whole of Hampshire and Isle of Wight. Obviously, the site will have to be given back, and is planning to be given back in October, because it is obviously our Brexit site. So we are working. So we have a testing operations cell. So testing is led across the local resilience forum, and all local authorities are involved. So DPHs across manage that together. And currently there are plans in place for the new regional testing site to be elsewhere. I'm saying that because I don't think it's actually been announced yet. I'm looking at David. So it's imminently to be announced, but it isn't in Portsmouth, but it isn't far. So there'll be a new regional testing site online at the same time as the Titner site is closed. And also, because we're conscious that we have been very lucky in Portsmouth to have both a local testing site in Eldon, which is a walkthrough, as well as the drive-through at Titner, we are arranging for there to be another local testing site, again to go live around the end of October, which will be in North Portsmouth, site still to be confirmed. But there's also, as well as local testing sites, which across the whole of Hampshire and the Isle of Wight patch, there will be a further 8 in October. By the end of October, there are also mobile testing sites that move around the whole patch. So there will not be a problem with access to testing, I would like to say. However, the current situation, as you know, is with the increase in demand on testing, which has gone up considerably, obviously linked to people returning from holiday, schools going back, and also infection rates increasing. There are lab capacity issues at the moment, but that is also being currently, I'll use the term, sorted by DHSC, and we're hoping that the lab capacity will be back to meet their current demands again over the next, I think the Minister said, Secretary of State said, few weeks. So I'll leave it as a few weeks.
No, that's reassuring, thank you, because it's just obviously a worry if you hear something's being taken away, that obviously that there's plans to replace it and obviously enhance it, so that's good to hear.
Thank you. Anyone else with any comments or questions for Helen? No, thank you very much. That's really helpful and really informative, so thank you. Right, can we hand over to Michelle for the finance and performance reports, please?
Yeah, thank you, Elizabeth. I'll do them separately, do my usual introduction and then open it up for questions, if that's okay with everyone. So the papers that you received were up to month 4, and at the time of compiling that report, we had just received the retrospective top-up linked to months 1 to 3, and I can confirm that we received it for month 4 as well, and that would take our position back to a break-even position as described in the report. In terms of month 5, we've done some further work with the mental health commissioning team on the mental health extra contractual referral situation, just so that we understand that a little bit better. And as a result, we are seeing a slight slowdown in the expenditure, and the teams will keep continually looking at what are we recording, what are we anticipating, and making sure that we keep a watchful eye in that area, and then also looking at patient pathways, etc., and see if we can maybe change some of our approach, in line with all our transformational work. So really good joint working with our council colleagues as well. And to that end, we also improve our relationship from a financial point of view, and we're making sure that we've got some good financial governance around all the COVID-19 expenditure that we are incurring, both from the CCG point of view as well as the council, and in particular around the hospital discharge programme. And again, we're trying to make sure we've got an aligned approach for those programmes of work. As we've heard, the Hampshire and Isle of Wight are trying to finalise our response to the phase 3 part of the COVID response, and we are tidying up and resubmitting the activity, performance, workforce and parts of the financial plan. And the bit that's missing out of the financial planning process at this current time is until as of late yesterday evening, we hadn't had the updated financial framework. So that, along with the guidance that Linda mentioned earlier, was released yesterday. Timing not entirely brilliant, because of course we are trying to make sure that we land some plans before we knew that framework. So I think it's important that we finish those plans and understand what people think they do need to spend, and then we have to compare it to the envelopes that we have received and see what we can do to improve our performance and our activity within the sums of money that we're expected to work within from a health and care perspective. And I say health and care because the hospital discharge programme is also changing, and we need to make sure that we're aligned with that going forward as well. We also should note, in terms of the way that the new financial regime will work, some of the top-up process that we have been receiving on a retrospective basis, those pots of monies will be given to SDP. So they'll be given to Hampshire and Isle of Wight in some shape or form. So we need to understand how are they calculated, and indeed how and how much are we requiring those top-ups ourselves. So the teams are going to be busy over the next few days trying to understand how that financial regime has changed, and it has changed quite a lot in terms of what's included and what is excluded, so that we make sure that as a CCG we remain within a balanced position for the financial year, which is the expectation. I think I'm going to stop at that point and open up for questions on the finance report.
So, any questions, Michelle, please? Silence, Michelle.
Let's move on.
Get quick while you're going ahead.
I have to say, it is a very strange world we find ourselves in, but we need to make sure that we're paying attention to everything that's going on, and make sure that we do get our share of the monies. But indeed, we do need to make sure that we are putting on services that our population require. So turning to the performance report again, I won't go through it in any great detail, just give you some an overview. In terms of performance indicators, nearly all the indicators have been reported upon. In terms of how we've reacted to that through the COVID-19 response, clearly we haven't necessarily been managing in the same way as we would have done ordinarily. So as expected, some of those performance indicators have slipped in the duration. However, some have improved as well. So we shouldn't lose sight of the fact that we have maintained some of those performance indicators despite being in a COVID-19 response situation. The main areas of deterioration are around the elective performance, and we are seeing an increased number of patients waiting more than 52 weeks, and the diagnostic waiting times we've reported before, haven't we? Those have also deteriorated. On the positive side, we should note that actually, certainly for our patch, cancer targets have been maintained, which is a good thing, because that has been in the public arena, hasn't it, in terms of it's newsworthy. But we have done very well, I think, compared to others over the last few months. And indeed, we heard some of the areas where we want to embrace the change, don't we, through the COVID-19 response, and make sure that we get that embedded as an ongoing process. So we heard about advice and guidance in particular earlier, and that is definitely a success story that we need to make sure it doesn't slip because of some potentially other perverse incentives to encourage more activity, etc. So we're just keeping a watchful eye on that particular area. In terms of response in phase 3, elective waiting times is definitely appears to be number one, but also we are expected to achieve the mental health investment standard as set out pre-COVID. So that is something that we need to make sure that we have been keeping our eyes upon, and I have to say is something that we were aware of, and we have been trying to make sure that we stand up as much of what we were intending to that we could during the intervening time. The intention is for the remaining months of the year to ensure services do resume to normal levels of activity, clearly in a COVID-19 safe way, which might mean less efficient ways potentially because of, you know, cleaning down and all of that goes with that. But we need to make sure that we continue good use of public money and that we aim to achieve a financial break-even position. So it's vital because clearly we've only just had that guidance, just had the new financial framework. We need to understand what does that mean given what we're trying to put in as a response to the phase 3 planning process. So it will take us a week or so to work through that and understand the ramifications from the CCG's point of view. Stop.
Lovely, thank you very much, Michelle. I think I am particularly proud of the cancer performance because so many areas have really dipped with that. We're aware that referral numbers did drop early on, but overall we've done brilliantly as a system around that. So yes, I think the one thing I would say about advice and guidance is it's a great thing, but we do have to keep a weather eye on the impact on primary care, because in the past primary care could do a letter, refer a patient, and off they went. They then came back having been seen or been spoken to or whatever, and then we do, you know, carry on the actions. We are now in the driving seat of having to enact that advice, so there is quite an impact, and we need to be keeping a weather eye on that and just see whether and what might need tweaking. So yes, it's great, it's working well, and from a patient perspective it's brilliant, but as a balance between primary and secondary care, I would suggest we need a weather eye keeping. So that's enough from me. Graham.
Yeah, I just echo that some of the performance, given the difficult circumstances we've been in, has been sort of really good. So that's really nice to see. Just a couple from me. Obviously, the 52-week wait times have increased naturally. I'm just assuming as part of phase 3 that those people will generally be prioritised for treatment. And the last one was the out-of-area placements, which I know is right at the end of the report, and that we were seeking a bit more detail from NHS England at the time this was written. I just didn't know whether we'd had any response to that yet, because I know it seemed quite surprising that we had that number.
Yeah, I think there's a couple of things to say to that, Graham. No, we haven't had an update. The reason why it says 5 is to do with potential identification. So it could be 1, it could be 5, but I don't know the answer to that. Yeah, it's sort of like a rounding thing that they tend to do in that area. The last time we had one of these clients, it transpired it wasn't our client, and it took us a long while to establish that fact. So yeah, so we're on it, and we'll update as to whether that person is indeed ours, because clearly if they are, our teams need to know who they are and understand whether there are alternative measures that could be put in place.
Thank you.
Yeah, can I just come in on the 52-week wait? There is some recognition that there are going to be people on a waiting list who may no longer need the procedure. For example, a relatively frail older person who was down for a hip surgery may have changed their minds, may no longer benefit from that surgery. So there is some work going on to validate those lists, to check out and then prioritise. So PHU, Portsmouth Hospitals, University Trust are looking at how best to do that. But it's work in progress.
And Elizabeth, again, it's worth saying that compared to other trusts around us, they are doing relatively well as well. So
absolutely. Absolutely. It's a manageable list at the moment.
It is manageable. Clearly disappointing because we were doing really well in terms of 52 weeks previously. But, you know, that said, compared to others, we see, and of course, if we continue to do the advice and guidance and find other ways of managing referrals, that gives PHU an opportunity to focus in on those long waiters too. So that's what we're trying to do, get a balance of all of those things. It's really difficult, isn't it, when you
this is a
people and making judgments, etc.
So we've got Jackie and then Nick.
I had a couple of questions actually just related to the last conversation. So one of the things that was in the performance report on page 7 was around primary care networks being able to help manage long waiting lists, and I just wondered whether we felt that they were developed enough to be able to take on what might be required of them nationally, put it that way. And then the other sort of part again around the waiting list standards and times was around looking to perhaps St Mary's and Gosport to work on minors, however also appreciating that Care UK is struggling with vacancies. So is that an added pressure, and how do we manage that? Making sense?
Yeah. Certainly about the elective care bit there, Jackie, it's one thing that we are doing well as a whole system. So we're looking at the whole resource across the piece and looking at hospitals working together to try and hit these targets. So Care UK resource will be amongst that in terms of conversation. And there is, you know, we are in active conversations. So if Southampton, for example, have got resource, how can Portsmouth patients benefit from that resource and vice versa? So that is one conversation where Hampshire and Isle of Wight actually is probably the level to do it at amongst all the acutes.
And in terms of the PCNs, are we confident that they're in a position where they can do what might be being asked of them?
Jackie, in terms of what we're asking the PCNs to do, it will be linked predominantly to the long-term financial plan and expectations around that, you know, that sort of workload, joining up resources, hot hubs and all of that sort of thing. There are ongoing discussions about whether that's what we need for the city or not, and how do we continue to manage the various work streams, given that the expectation around second wave as well. So I think your questions, although separate, the answer is we're trying to work as a system to make sure that we're utilising all the services that we possibly can. And whilst Linda's mentioned Care, and you've mentioned Care UK, there are two parts of Care UK. So there's the emergency side of it, and then there's the elective side of it. Well, the elective side of it is being paid for nationally. So we need to make sure that as a system we're utilising that to best effect. And also linking in to our other transformation project of the transforming urgent and emergency care, you know, manoeuvring things in a way that when we come out of it, we might end up closer to our desired outcome for that process as well. So there's lots of moving parts, but ultimately we're just trying to make sure that we're utilising the resources that we've got available to us to best effect. And actually, I think COVID-19 has brought people together better than we could have ever achieved if we were talking about this at Christmas time, for example.
I was just going to say that, Michelle, the PCN directors are really engaged. They're really, you know, we have regular meetings with them. They're really engaged, and their practices are really had to support each other through COVID. And so, yeah, I think we've moved quite good steps with the PCN development. But obviously, we need all the guidance about what they're expecting from them before we can work out whether they can do it or not.
And that would be the same for any service, Jackie, not just primary care. Workforce across the piece in a lot of areas are scarce. There's lots of things we would like to do, but we recognise that there are potentially limitations on workforce.
Yeah. Thank you very much. That's very helpful, and I do appreciate the complexity and actually the amount of effort that's gone into, you know, the work we've really achieved so far. Thank you.
So, Nick.
You're on mute, Nick.
I just wanted to ask about audiology. That was mentioned briefly in the kind of annual report, and it's sort of second in line after ultrasound as one of the big long waiters. And I'm certainly hearing anecdotally out in the community that people are a little bit concerned. So have we got any info we can share about sort of recovery of that at the moment?
I'm going to ask Linda if she knows any detail. Otherwise, I'd have to take that one away, Nick, as a specific.
Sorry, Nick, can you just refresh that again?
It was just on page 8 of the report that mentions about sort of audiology is the kind of second highest rating sort of diagnostic. I know ultrasound has been worked through and that's sort of been dealt with. So just in terms of where we are with the recovery of audiology, because I know anecdotally I'm hearing from colleagues that they're concerned a bit about the sort of long waits with audiology and how we've got with being able to sort of restore that.
I'll have to take that. I'll take that question away to. I've got a meeting with Lynn next week, so I'll find out where we're up to with audiology and bring it back.
Thank you.
Right. Any other comments or questions around the performance report? Okay, so we're asked to accept these reports, and in terms of the finance report, we're asked to note the retrospective allocation that we have received in financial terms. People happy with that?
Yeah, noted.
Yeah. Lovely, thank you very much. So moving on to quality and safeguarding report from Karen.
Yes, thank you, Elizabeth. The Quality and Safeguarding Committee continues to meet monthly on a virtual basis. So the report that the Governing Board has is the report that was considered by them in August. It follows the familiar format I think people are used to now. A couple of things to note. We don't directly manage or monitor the quality risks for PHU. That's Fareham and Gosport, but the committee agreed to close the risks on. Well, Fareham and Gosport have closed them, and we agreed that we'd take them off our risk register as well. So we've a number of risks that have been. Some of them have been on there for over a year, some 2 years. So it's good to see some of these risks come off of the risk register. Just specifically, the one around restraint practices that emerged last summer, which was quite alarming. A lot of work has gone into completing an action plan, making sure everybody's trained, that much better reporting of any incidents, and teams are working together. So that's now come off of the risk register or our risk register. The risk around patient safety investigation process has come off. I think they introduced a new system and they're now comfortable that that's been well embedded. There was a risk around patients requiring mental health care provision for both adults and children. I think COVID introduced a new pathway for people with mental health needs, and so that risk has now reduced and has come off of our risk register. I think what we're conscious of is some of our risks have reduced, and COVID has supported that, and these may well emerge in the future. But for now, they're off of the risk register. And the last one was around communication between providers. This is specifically between maternity and health visitors, and there's a lot of work that's gone on between those two services, bringing those services together. So that one's come off of the risk register. We've also reduced two risks. One again is PHU, and that was around safeguarding. That mainly is around training, and they've restructured their safeguarding and introduced new member of staff, but also training and processes have improved. So that still remains on the risk register, but it is reducing. And the last one to change or reduced is around care homes. We've reduced the risk relating to our care homes suddenly closing, and because it was on there around. Because they were inadequate and not particularly, we were concerned that the CQC may come in and close them or insist that they close. Because none of them are inadequate now, that is reduced. We are aware that there's an emerging risk around care homes are significantly reduced in capacity, or not capacity, they've got vacancies, and they may therefore choose to withdraw from the market. So there is a similar risk emerging, but at the moment it's not something that we're noting in Portsmouth. We've just noticed outside of Portsmouth that sort of thing is happening. The other thing to note is we have St Mary's KUK Urgent Treatment Centre on our risk register anyway because of the number of clinical vacancies, but throughout COVID, or at least more recently, we were concerned that they weren't able to deliver a service at UTC and were frequently, we thought, redirecting patients to ED, and we were concerned about that. So the quality team have been in and done a number of visits, 2 visits, at times when they've been particularly busy at the UTC, to just try and understand what's actually happening. The feedback we received today, and it's not in this particular report, but the feedback we've received today is that it's running very well organised, and people are expressing satisfaction about the service that they're receiving. In fact, of all the people we spoke to, all of them were happy with the service they'd received, and none have particularly had to wait long. We are told, though, there are times when staffing does reduce, and they're the times when people are redirected. But on those occasions, KUK are saying that they're actually liaising with ED and saying that they're sending these people up to them, and at that point they think everything's okay. And it's only happened on 2 occasions. We don't know, but that's the information we've got. But anyway, we are aware of the issue, and the quality team are working closely with KUK just to monitor and see if this actually is anecdotal or whether it's actually happening. The last thing, perhaps just to mention, but is no longer actually an issue, is that Ferrum Gosford had written to SCAS regarding what we thought was a number of safeguarding issues regarding children not being transported to hospital. We've now been able to look into that a bit more. They're not necessarily safeguarding issues. In fact, most of them weren't. And I think we've got confidence in what was being asked of SCAS. So we're less concerned about that as a quality issue. I think that's probably about all, Elizabeth, unless you've got any questions.
Lovely, thank you very much. So, any comments or questions from people? Stunned silence. I had one around the care homes. You were saying it doesn't appear to be a problem in the city. Is that because our vacancies are spread out across the care homes rather than any one care home being particularly empty? Or
yes, I think we're aware that they've got vacancies, but not so significant. They are spread across. But we'd heard that other care homes happened at other care homes outside of Portsmouth. So I think we're just on the alert, really, and aware that it's not beyond the realms of possibility that it could happen in Portsmouth. But yeah, no, I don't think it's around one care home having many vacancies that it would need to close at the moment.
Right, thank you. And then the other one, and I'm not sure whether this comes in under your remit or whether I should be going off and asking someone else this question, but I know there's been talk that the UTC is quite keen to move to an appointment system using 111. So along the lines of ED and 111 first, has that crossed the quality and safeguarding team?
No, we did have Mark to the meeting in August, and we talked particularly about the UTC, but not that particular issue.
I just wondered whether that was linked to their vacancy rate and whether they could then spread demand as it went out.
Yeah.
I just wondered whether there was anything there. No, that's fine. I will speak direct to Mark and find out whether what's driving that. Jackie and then David.
I was thinking about the risk that was on page 8 from PHU and the risk about not being able to manage self-presenting patients and not having any clear oversight. I just wondered what we're doing about that or what was going on.
So I think that's in terms of self-presenters bowling up to ED and then ED waiting room being overfull and having people queuing. And this is where 111 First has kicked in, and we've been an early adopter of that, such that it reduces the footfall through the door in the first instance because people contact 111 first and are clinically triaged through the CAS, as Joe was talking about earlier on.
Yeah.
For those who self-present, who have not heard the message, which hasn't been widely publicised as yet, but for those who do self-present, they are now putting in a navigator who checks that someone hasn't got any red flags, so that they've not got crushing chest pain or that they're not bleeding or whatever. And then they are encouraged to go to 111 either on their phones or on iPads at the front door in cubicles.
Yeah.
And then follow the advice from there, which is usually go away and wait for a phone call. And they've done 4 perfect days so far on that, which went very well. And the plan is to roll that out shortly so that anyone self-presenting will be triaged before they move into the department. And if they need to be in the department, they will be given an appointment. So it keeps people safer. So you don't have 50 people in a, well, I'm sure you've been to the ED. It's not a big waiting room. And as a point of infection spread, it could be significant. So that's what they're doing.
And so what happens for those people, and I'm thinking of my own stepdad now, and I wouldn't be able to help, who are not familiar, don't want to use an iPad, not interested in using an iPad.
Phone. They can use a phone to ring 111.
From within the area, or you have to be mobile?
Well, if you've got your own mobile, if you've self-presented and you'd be encouraged to use an iPad or your own phone to phone. Obviously, if there is someone who is unable to do that, they are supported.
Okay, thank you.
So no one will be left with no help. It may not be the help they think they want, but they
Okay, that makes, exactly. Thank you, Elizabeth. And in terms of like the other risk that came up on page 4 was around 3-hour discharging and embedding that. And I didn't, is that a newish standard? Where's it come from? Sorry, Karen.
Where's that, Jackie? Sorry?
It's on page 4, helping embed the 3-hour discharging and same-day discharge metrics. Don't worry, I can always maybe email you afterwards or something. I don't take.
The 3-hour discharge standard came from the discharge guidance at the beginning of the COVID response and has formed a way of working as we've gone through. So, I mean, whether we can argue whether 3 hours is right or appropriate, that I think we'd agree that actually getting safer, quicker discharges for people who don't need to be there is a generally good thing. So I think it's about continuing to do that as well. So and we have integrated discharge arrangements, not just between the council and the CCG, but with Solent as well, which have been successful in doing that consistently over the previous months.
So you're saying it's been pretty good, whether it's within 3 hours or not. We've been able to provide a safe quality discharge service.
Yeah. Yes.
Thank you.
Lovely. So we've got Carsten and then Nick.
Yeah, just hi there. Thank you for that. That was really informative. I'm just looking at the risks, the IT support for remote working. I assume there seems to be a bit of a problem. Is that more of a technical nature, or is that an investment nature? It says that the
Does that to do with the MASH?
Yes, the MASH.
That's been resolved.
Okay, that's cool. And the other one is that the referrals were of the JTI came to the conclusion that the referrals from possibly from primary care and possibly also from me were of poor quality. Has there been any sort of training? Obviously, that's what it always boils down to. And would that be something for the next target? To revisit MASH referrals? It's always a challenging thing to tell GPs how they should. Yeah.
I certainly know there was a long action plan that our quality team were working with Portsmouth City Council with and Alison's team to work through. I haven't had any feedback about that where that's at, and I know some of that was going to go to target. But I can follow that up.
So, yeah, I can come in with a bit of it. So there's work has gone on about looking at how MASH works and how there's that feedback loop is better, because currently I think many GPs would say that they struggle, that they make a referral and then it just disappears and they don't get feedback. So we're looking at strengthening that feedback loop, which should then improve the quality of referrals, because if you find out you've got it wrong, at least you'll know now, and that there will be that continual improvement. So that flow chart is being worked on. We do have target in 2 weeks. I'm not sure that necessarily it's directly in there, but it is some case discussion, which hopefully will help, and we will be looking at it further.
Good.
But
it's just that's fine. It's just for our safeguarding training. It might be a good topic to focus on soonish. That's great. Thank you.
Safeguarding training has been planned, hasn't it? So it's whether the agenda for that.
It's the end of September. It's already set up, but I haven't been directly involved, but it's work in progress.
Okay, thank you. That's great. Thank you, Karen.
Nick.
Yeah, it was just a quick thing, just to pick up, maybe just to clarify the point that Jackie was making about the iPads and the redirect from A&E. But if obviously you mentioned people are encouraged and supported. If somebody absolutely says, I don't want to use an iPad, I need to be seen by whoever, what happens in that situation?
I don't know. I haven't been in the department.
Because I think there may be a situation. I mean, I don't envisage. I think if it's being done well and people are being communicated and supported well, that should happen. But I guess just maybe to inform us and maybe people watching this to understand what happens if you absolutely think, this isn't for me. I don't fit in this. I really want to see someone, and what happens in that situation. Because obviously we wouldn't want someone just being pushed out of the door when maybe because there is obviously a risk of that sort of safety issue of that. I don't anticipate it being a big thing, but I just thought it's an eventuality we should maybe address.
Whatever happened to the Luddites?
As far as I'm aware, it was very well received on the days they've done it so far, which is why they're planning the rollout. So far, they've not had an issue. They will be keeping a very close eye on it, and obviously if someone is very distressed and feels they can't do it, they probably need help there and then anyway. So I think that all has to be taken into account. So yeah, it's a watch this space. Okay, Linda, do you want to come back in on that?
Yeah, I mean, obviously I do some of these calls because I work for PPCA, and the service we offer is very rapid, so patients do get called back relatively quickly after they've done these online or their telephone into 111, and then they're usually offered a solution to their problem relatively quickly, either by our usual general practice telephone consults. We do the video consults still, and all the stuff we're doing in normal daytime general practice, and obviously if we need to see them, we can usually offer them an appointment to place relatively quickly, and certainly a lot quicker than sitting in an A&E department for 4 hours, which will then hopefully encourage next time, actually I won't just turn up, I will phone 111. So I think because the quality of the service we're offering at the moment is very good, it will hopefully spread the word and will help in future.
And I know that as things are more embedded, that there will be more of a publicity campaign, so fewer people will turn up without having called 111. So if we can reduce the footfall at the front door, that reduces the opportunity for conflict. So I know there is a comms plan in place. So, Carsten, did you want to come back in, or are you an old hand? Right. So anyone, any other questions or comments for Karen? Okay, thank you very much for that comprehensive report. We're asked to accept the report with the noted with the highlights and the change in risk. So people happy with that?
Yeah.
Agreed.
Stuff. So Jackie, hearing from patients, carers and service users, over to you.
Oh, can you hear me? Didn't I turn off before?
Yeah, I can hear you.
Oh, thanks, Andy. I hope you've had a chance to have a look through the report, and I was just going to say thank you for David Barker for pulling this all together. I think it's pretty obvious that we have been impacted by Corona, but the team have done everything they can. There's still real variety in our attempts to reach out to people and to get comms and engagement. But Corona has had an impact. The comms team, what they haven't put in the report, I think, is that they've still reached out to staff. So we've had within the organisation, within the CCG and hopefully PCC, information about where we are with Corona, and actually insightful stories about how people have managed, how the GPs have managed, how physiotherapists have managed, this sort of thing. So the ball has been kept rolling as much as we can do. The other thing to note is that we've had a change of hosts. So the City Council will be hosting Health and Care Portsmouth comms and engagement, and that'll be led by Cheryl Scott and I think Lucy Elliott as well. And there's a whole team there. So I just think we've got a lot to look forward there, and also to thank the people that have also contributed up to this point as well. And I guess my challenge out there to ourselves is that we make sure that we keep our comms and engagement link across the wider footprint, be it at our sister CCG level or across the SDP. So we just need to make sure that we have that continuity of comms and engagement, and it sits where it needs to for our particular bits of work. And really, the other thing, there is going to be other changes. We've had this one thing that's mentioned in the report is that I've hosted the citywide PPG for a number of years. It stopped because of COVID, but we need to look again, I think, on how we do that engagement, especially with PCNs coming on board. So it's part of I suppose, a package of work about how we take this forward and make sure that we do maintain that meaningful comms and engagement that makes a difference to us a lot in a way that influences the way that we do commission work, and just makes it better commissioning, I think. So I hope you've had a chance to have a look through, open to any questions, and I'll just point at Innes for the answers.
Oh, you're on mute, Elizabeth.
Mute. Linda, your turn.
Yeah, no, it was just a comment. So I was at the Health Watch public board last week. They do it via Teams, similar to how we're doing this. They're very keen on obviously making sure patient engagement runs through all of our programs, and they've offered obviously any assistance. So I would like us to work closely with them to make sure that we're getting the best out of their networks as well.
Yeah, absolutely. I'll make a note.
Yeah. The Siobhan was very keen to work with us, and obviously they've got lots of networks and lots of mechanisms, and so if we could work together on utilising them, that would be very beneficial. I've offered obviously that we can go to their board whenever they would like us to, and just try and improve that relationship there as well.
And they were regular attendees at the citywide PPGs as well, and very valued ones as well.
Yeah.
Any other comments?
I would just add, I was just going to add that I think the shift to having a integrated team with the City Council actually now gives us an opportunity, I'm hoping, unless David starts shaking his head, to utilise all those wonderful things that the council does and has in place, engaging with local communities. These are things that we've never been able to quite get underway. So I know that the team is already looking at that. The council's got a very good way of engaging and communicating with local residents, and we're quite keen to explore how we can push health and care into some of those ways of talking as well. It's something we've had an ambition to do for a number of years, and this finally gives us a mechanism to do that, I think, as well. And certainly the team themselves are quite keen to do that. They only picked it up at the beginning of this month, so I think we need to give them a bit of a chance to get their heads around that. And it may be, Jackie, that a conversation specifically around the PPG would be useful, because there may be ways and means of doing that. That might be different to how we've done it in the past, but might actually reach more people as well.
Thank you, Ines. And actually, Cheryl's been great. I did email her on exactly that, and she's given a bit of feedback, and we're hoping to meet up along with Cherry, I think, very, very soon. 21st? Yeah,
okay.
Hopefully. Thank you.
Good.
Yeah, thank you, Ines, because I was just going to say this very same. We've aspired to doing things along with the City Council over many years, but have never quite managed it. So hopefully we can now. That'll be good. Any other comments, or are people happy to note this report and the great work that's being done?
Happy.
Lovely. Thank you very much. Moving swiftly on, we've got some rather elderly minutes of other meetings. So Primary Care Commissioning Committee of 28th of May to note. I don't know whether anyone has anything to say about those. Nick, you were there. Anything particular off them? No. Lovely. Right. Thank you very much. So, date and time of next meeting in public is 21st of October at 1 o'clock, and it will be live, be streamed online via Teams again. Thank you all very much for attending, and we can now close the live streaming. Thank you, and turn the recording off.
I'll go and do that now and confirm when it's stopped.
Thank you very much, Peter.